So, oral cavity, you used to get to see that there is the epithelial tumors, there can be the mesenchymal tumors and hematolymphoid also. Obviously, the epithelial tumors are much more common. Among the mesenchymal tumors, we used to get malignant mesenchymal tumors. We used to get the rhabdomyosarcoma, the osteosarcoma arising from the mandible in some cases, fibroblastic tumors, liposarcomas and leiomyosarcoma. The hematolymphoid tumors, we used to get the high-grade hematolymphoid B-cell like bucket-like lymphoma from the mandibles, low-grade lymphoma like malt-associated lymphoma from the salivary gland structures, as well as the hematolymphoid tumors with plasmacytic differentiation, plasmacytoma or multiple myeloma. So among the epithelial tumors which are much more common, we can get the tumors from the lining squamous mucosa of oral cavity. We also can get the salivary gland or salivary duct origin tumors, as well as we also get from the tumor arising from the odontogenic epithelium. So odontogenic epithelium origin tumors, there is a very big list like adenomatoid odontogenic tumor, squamous odontogenic tumor, calcifying epithelial odontogenic tumors, amyloblastoma, amyloblastic carcinoma. So I'm not elaborating or stretching the list. Our point of discussion is here now is basically the epithelial tumors of the oral cavity, malignant epithelial tumors like the squamous carcinoma. So squamous carcinoma morphologically we subdivide in these types like Anyway, so subtypes is first is basaloid squamous cell carcinoma. There is acantholytic spindle cell and all. So basaloid squamous cell carcinoma is a very aggressive type of variant where the tumor cells show the palissading appearance. There is a high NC ratio, blue-looking tumors. In oral cavity, it is not a problem, but from the other part of the body, like in the skin and the cheek, basically, there are also the basal cell carcinoma also. So morphologically, there are some form of similarity. So in that case, we may require the IHC to differentiate from the BCC from the basal cell carcinoma from the basaloid squamous cell carcinoma, because the latter one is very much aggressive, while the BCC is absolutely an indolent kind of tumor. Acantholytic SCC is a variant where the cell additions are lost, so the tumor cells basically. Okay. So acantholytic SCC is another variant where the addition molecules are lost between the tumor cells, so they are dispersed and there is an easily chance to metastasize to the nodes and other part. Similarly, the spindle cell SCC is very much a point of concern because there is always a differential diagnosis, close morphological diagnosis is the sarcoma, spindle cell sarcoma. So we may require the broad panel of IHC like P63, P40, HMWCK to differentiate from the spindle cell sarcoma and the sarcomatoid carcinoma or spindle cell sarcomatoid carcinoma. Adenosquamous carcinoma is another variant where both the glandular and the squamous differentiation is there. Papillary SCC is very rare but also can present, and lymphoepithelial-like carcinoma, that is look like the nasopharyngeal undifferentiated tumors. The tumor cells arranged in very much syncytiums in amidst with the lots of lymphocytes and plasma cells. So these are all the morphological subtypes and they have some clinical significance depending on their biological behavior and aggressiveness. So cause of the SCC, most common cause in our country is the tobacco, either chewable or smoking. Both kind of tuberculosis are responsible. HPV is an important factor for the oropharyngeal cancers, but in oral cavity squamous carcinoma, their roles are very much limited. So oropharyngeal cancer basically they present like the very small lesions in the oropharynx and the large node, basically cystic nodes in the level 2 and level 3 regions. SCC that is associated with HPV in oral cavity, they are morphologically a little bit different from the non-HPV associated or the tobacco-related SCC. HPV-related SCC, they are the exophytic and the smooth contour with surface ulceration is there basically. So, this is the morphological difference. And how can we diagnose the squamous cell carcinoma? Just very few points I will discuss with you. So first we look at keratinization is there or not. If keratinization is there, then our almost it's very easy to diagnose. But some squamous cancer is non-keratinized. In that context, we have to look their cytoplasmic appearance. In squamous SCC carcinoma, we basically see the glassy eosinophilic cytoplasm full of the keratin materials and the pleomorphic nuclei and all. So sometimes we also look very much deeply to see the desmosome, cell adhesion molecules. That is another important clue to identify the squamous cell carcinoma. If it is a very much poorly differentiated, then we may require the immunohistochemistry. In some cases, P63, P40, these are all helpful markers to differentiate it from other type of the tumors. Okay. Next slide. So this, apart from these full-fledged and full-frank squamous carcinoma, there are also the pre-malignant lesions. So oral potentially malignant disorder. So this oral potentially malignant disorder is a very broad heterogeneous group which contain the clinically defined entities, and sometimes they are the clinically visible lesion also there. And these different clinically defined lesions have the different risk to progress to the squamous cell carcinoma. So in this entire list, I will just discuss few with all of you. The number one is the leukoplakia. So it is the white patch-like lesions which appears in the oral cavity, hard palate, and in the lateral border of tongue or ventral surface. So leukoplakia, they are slightly elevated in morphologically, appearance or elevation slightly. They can be flat with a smooth homogeneous surface, can be granular with nodular appearance. Sometimes there are fissures, verrucous-like appearance can be there, and they microscopically they have the dysplasia. So moderate to severe dysplasia is present there. So morphological clues under the microscope, the dysplasia is pleomorphism, nuclear atypia, atypical mitosis, and the most important is the loss of polarity. So usually we used to get, that is for my pathology colleagues, usually we used to get the immature cells at the basal part of the epithelium. Once we are getting the cells which have the immature in appearance, high NC ratio, less cytoplasm, nuclear pleomorphism, involving the more than half, more than one-third of the epithelial thickness, then this is known as the loss of polarity. That is a very important feature for the dysplasia. So apart from the leukoplakia, also there is another entity known as the erythroplakia, that is slightly depressed red velvet-like appearance, and the chance of high-grade dysplasia is much more common in erythroplakia. There is the submucosal fibrosis, and already I have discussed also to some extent the HPV-associated mucosal dysplasia also can be present. So now another important concept I want to discuss with you, that is the field cancerization, concept of field cancerization. So this field cancerization is very much well established fact which shows that there is a transformation of the pre-malignant lesion to the frank malignancy, and sometimes this pre-malignant lesions is not morphologically well established. There is the genetic levels abnormalities present in these pre-malignant conditions. And this field cancerization concept gives us the throughput that squamous carcinoma in oral cavity is not an isolated cellular phenomenon. Rather than it is a process of pleomorphism, process of the anaplasia involving the multiple focus due to the carcinogens, specifically on the chewable tobacco or the smoked tobacco. And due to these carcinogens, there are the process of pleomorphism, anaplasia happens in multiple focus. And these all anaplastic focus have the different rate of transformation into the frank cancer. So that's why there is a high chance of the local recurrence, high chance of the second primary in a oral squamous cell carcinoma once treated after operation, surgery or radiotherapy. And in the field cancerations, basically morphologically we can get the defect like a form of leukoplakia, erythroplakia, submucosal fibrosis I already discussed. Apart from these, there also maybe also the non-morphologically evident situations where the genome level abnormality is present. There are the lots of cell cycle regulator genes, proto-oncogenes, tumor suppressor genes like P53, P16, cyclin D1, ERBB1, RAS. There are the either genetic or epigenetic alterations which present as a clonal expansion and further development of the squamous carcinoma, frankly. So there are the different stage. Initially there is a patch stage. Patch stage means when the cells which have the genetic abnormality, genetic signature for carcinogenesis, these cells expand. These cells show like a population of the monoclonal population of cells. That's called the patch stage. Once these monoclonal populations expand themselves, is the clonal expansion. and then ultimately there is a disruption of basement membranes, and finally it is the appear as an invasive squamous cell carcinoma. So these dysplastic cells, there are the two hypotheses. One is due to the saliva there is a micrometastatic drop metastasis into the different part of the oral cavity, or there may be another hypothesis, there is the intraepithelial migration of these dysplastic cells. It is not metastasis because these dysplastic cells not come out in the lymphatic area, but there is a trans-epithelial migrations, and in different part of the oral cavity they can produce these, they show the clonal expansion and finally the film-filled squamous cancer. Clinical implication is that I already discussed. That's why there is a chance of second primary and chance of the recurrence is very high in squamous cancer once this squamous cancer is due to the tobacco or any other type of the carcinogen. Another interesting discussions is the verrucous carcinoma. So verrucous carcinoma is basically a well-differentiated non-metastatic squamous neoplastic lesions which appears as a warty keratinized surface dorsally or macroscopically. In microscopically, we used to see, apart from these, the exophytic papillae-like appearance. In microscopically, there is the endophytic growth of the multiple papillae, and there is no infiltration of the stroma. There is basically invading the stroma evenly in a finger-like pushing borders, and there is the very well sharp defined stromal and epithelial interface, and this interface basically contains the plenty of lymphocytes and plasma cells. So verrucous carcinoma, there is a no pleomorphism, no ATPR, atypical mitosis should not be there, and if we can get these kind of the morphological features, systemological features in association the surface ulceration, then the diagnosis is questionable. And diagnosis of verrucous carcinoma in a punch biopsy is very difficult because as it is a exophytic mass, the punch will only show you the hyperplastic, hyperkeratotic squamous epithelium. So for diagnosis the verrucous carcinoma, we need a wedge resection at least. The entire lesions, if submitted by wide excision, it is easy to diagnose, but at least the wedge resection is required because the tumor and stromal interface you have to look, because this kind of the invasion in a form of the pushing border is very much required for diagnosis the verrucous carcinoma. So that's all, and just an image I want to share with you. I think apart from my pathology colleagues, the other clinicians also can have idea, should have idea in it. So this is basically a verrucous carcinoma lesion. It's exophytic, a warty papillae-like appearance, and you can see that there is a no ATPR, no atypical mitosis, nothing is there, no dysplasia is there. That is the very differentiation from the well differentiated SCC. In SCC we used to get the dysplastic cells, but here all cells are not non-dysplastic. And in these high power images that show that they show that even distribution of these pushing fronts of these tumor clusters. So that all have the pushing fronts. They never infiltrate. They invade in a pushing manners, just like finger-like manners. And there is a dense lymphoplasmacytic infiltrate here. So the diagnosis is basically a verrucous carcinoma. Okay, so this slide I want to discuss with you what parameters should be present in a histopathology report of wide excision of SCC. Maybe it is a wide excision of buccal mucosa or mandibulectomy or maxillectomy, bile composite. So lots of specimens we used to get. Number one is the tumor size. So tumor size is very important component in the TNM classification. It must be present there. Apart from that, the depth of invasion. Depth of invasion is another very important component for should present in the report. And one should keep in mind that depth of invasion is not like the third dimension of the tumor. It is not the tumor thickness. Just in two images I want to discuss with you. Suppose in this lesion, the tumor is basically ulcerated tumor. So this is its the depth of it. Its thickness is this. But for assessment of depth of invasion, we must make an imaginary horizontal line from this normal epithelial basement membrane, and from this line we have to calculate the highest depth of extension of the tumor clusters. So this is the actual depth of infiltration. So if a tumor is an ulcerated tumor, then obviously your depth of invasion will be more than the tumor thickness. So So that part you should keep in mind during reporting, and clinician also should check in a third that what is the gross description of tumor. Grossly it is, if the report you see that the grossly it is described as an ulcerated tumor and the third dimension is larger than the actual depth of infiltration, then that report is obviously erroneous. Similarly, for the exophytic tumors, the depth of infiltration will definitely be less than your third dimension, because the exophytic component will not calculate during the depth of infiltration. Always for calculation of depth of infiltration, we make an imaginary horizontal line from the normal basement membrane, and from that we have to calculate it. Why this is very much important? Because the AJCC 8 classification, depth of infiltration is an important component for the staging of the oral squamous cell carcinoma. Second is your margin status. So basically, in head neck cancer, we used to take the two kind of margins. One is the radial margin, one is the shape margin. In head neck cancer, we should keep in mind that all margins should be radial except the mucocutaneous junction. So if there is angle of mouth excision, which include the both lip, mucosa and normal skin, that margin is only the shape margin. Otherwise, all margins, all mucosal margins should be the radial margin. So that part also the clinician should keep in mind what margin they have mentioned. It should be mentioned clearly in the report, because in radial margin, if we get the radial margin is 5 mm away and free, that means the margin is the free of tumor, and there is a chance of recurrence, local recurrence is less. But if the pathology is taking the shape margin and it is just mentioned the one part of the margin contain the tumor, then you cannot make difference what is the distance from the tumor to the actual the free inked margin. So that's why in head neck cancer all margins should take as a radial margin. Now third thing that is also important is the WOPI. What's pattern of invasion means it is the clusters type 5 present or absent. So WPI type 5 means it is the clusters of tumor cells which are at least 1 mm away from each other. So WPI type 5 present is a bad prognostic markers. If it is present, then the chance of local recurrence is high, chance of nodal metastasis is high. Similarly, the perineural invasions, it is also an important parameter. So one should make in the report it is the intratumoral PNI or it is the extratumoral PNI. So if I get the PNI beyond the tumor gross area, then definitely is much more significant. It is a focal PNI or it is a multifocal PNI. And the mention of the large nerve diameter, which shows the PNI, that should present in the report. Similarly, the lymphovascular embolism present or absent, and extranodal extension, present or absent, must be maintained in the report. And preferably, still this is not mandatory, but in the coming WHO classification, big part will be included. What is the extent of perinodal extension? It is more than 2 mm or it is less than 2 mm. Once this data is much more powerful, definitely this part also be included in the TNM staging system. Last part but not the least is the underlying bone status. So sometimes we used to get the report that underlying bones is eroded, and the staging they are mentioning is not the T4. So one thing we should keep in mind that bone, mandible or maxilla, these bones have the two components. One is the cortex, one is the medulla. So cortex has an outer table and trabeculated area and an inner table. So once if only the tumor erode the outer table, then it is not the T4A. But once the tumor breach the outer table of the cortex and it's come in the medullary cavity, definitely it is the T4A stage. So just in this image, I just want to show you what should be regarded as the actual bone invasion. So see, this is the bone trabeculae, and between the bone trabeculae, these are the tumor clusters. So this is the keratin pulse between the bone trabeculae. So these all are the underlying mandibular bone or maxillary bone, whatever, it's invaded by this tumor.
If it is only outer table,
if it is only the outer table, then just periosteum only the involved, then it is not T4A staging. So that part should mention in the report very clearly.
So periosteum is different. If only the outer cortex,
only the outer
cortex is eroded.
Cortex is eroded. If the cortex is only eroded, outer table is only eroded,
but not the medulla.
Medullary cavity, then it is not the T4A.
Then what is the T3 or T4? What is it?
It depends on the size.
According to the size.
Yes.
Okay.
And depth of invasion.
DOIT obviously. Okay.
So this is the perineural invasion. So at least 1/3 of the nerve should be involved by this tumor. Here the entire nerve is encased by the tumor, And better to mention the nerve diameter. If it is a large nerve diameter, then they mention the nerve diameter that is involved. So that is the very in the short time period, the very minimum inputs on the pathology and what the component would present in the report. Thank you. Any questions from your side? I'll appreciate it.
There is no mic, but we will be audible. Anybody, any questions? 2-3 things. Transepithelial migration you were saying.